We're going to spend some time today talking about fragility fractures of the pelvis and looking at this maybe from a different lens as we think about whether we should have a paradigm shift in how we approach these injuries, given the context of what we're already doing for other fragility fractures. These are my disclosures. When we look at patients who have frailty fractures, we start with this young woman. She's 76 years old. She had a fall. She has significant pain. She's unable to weight bear. She cannot ambulate even with a two-person assist. Prior to her fall, she was a community ambulator, and she has the standard sort of medical problems that you'd expect somebody at 76 to have. Her x-rays show us a displaced femoral neck fracture. This is something that I think we all see. There's no red herrings here. And I think as we think about the treatment for a displaced femoral neck fracture, I don't think there's any regional, national, or international controversy around how to manage this injury pattern. When you think about that geriatric displaced femoral neck fracture, we want to talk about getting these patients to the operating room quickly. My favorite slide is the one on the right. But for this particular patient, we're going to treat her with surgery, typically as soon as we can get her appropriately medically stratified and clinically optimized, usually within 24 hours for our institution and many institutions. And the goal of care is to get her up, get her mobilized, and get her out of the hospital. I mean, it is a fairly consistent hip fracture pathway that most institutions have. And I think we all agree that patients like this do better with early surgery and early mobilization. And there's lots of literature to support this concept of early fixation of geriatric hip fractures with early mobilization, and it decreases morbidity, it decreases mortality, and we know there's clear benefits to this treatment. Great. We could stop the webinar here and call it a day if we were talking about geriatric hip fractures. So I'll give you this patient. She's 72 years old. She's exposed to fall. She has significant pain. She's unable to weight bear. She can't ambulate even with a two-person assist. Prior to this fall, she was a community ambulator. Her past medical history is what you see here. Sounds very similar to the patient that we just talked about who had the femoral neck fractures. In her case, she has this minimally displaced, barely visible pelvic ring injury, pelvic fracture in the front and in the back. You can barely see it on an x-ray. You need a CT to see it. I didn't put the CT in, but you'll have to believe me that she has a pelvic fracture. And her, what do we do with, right? With the hip fracture, it was obvious. When we talked about timing and treatment and goals of care, boom, boom, boom. And in this case, we treat her non-operatively because it's minimally displaced. It might be stable. There's really no timing because we're treating it non-operatively, so it'll probably be 3 or 4 or 5 weeks before she's really ambulating. Maybe she'll feel better in a couple of weeks. And some people will keep her non-weight bearing. Actually, at our institution, if we treat these with non-operative treatment, we make them toe touch weight bearing on the affected side, which is hard in a 72-year-old. So really, they're weight bearing with the assistance of a walker if they can tolerate that. So that's what happens to her, is she sort of gets put in this pathway of non-operative treatment, even though her picture and her history and her story are eerily similar to that 76-year-old with a femoral neck fracture. This patient was actually at an outside hospital, and she was at that hospital for 6 days with ambulatory dysfunction and pain. They could not mobilize her. They couldn't get her up with therapy. They were having difficulty with placing her, and that's when they called us. And we ultimately put a screw in her anterior column, a screw across the posterior aspect of her pelvic ring. She actually had bilateral, minimally displaced fractures. And at 2 weeks, this is her video from clinic, right? So at 2 weeks, she is fully weight-bearing with a walker. She actually left the hospital 48 hours after we fixed her. And so as we think about pelvic ring injuries in the elderly, do we need to start to look at these differently than we have historically? I'm going to come back to this patient a lot, but I wanted to paint this picture for you before we come back to her later. She's a 65-year-old female, status post to fall. She's got diffuse large B-cell lymphoma, some lytic lesions in her pelvis. Prior to her fall, she was walking independently. She is frail, though. But for 3 days, she's been unable to tolerate any weight, and she was sort of labeled as a fragility fracture of the pelvis and kept sort of treated initially non-operatively. When we think about fragility fractures of the hip versus the pelvis, it is, to me, a stark contrast in management and treatment. While the incidence is roughly half between hip fractures and pelvic fractures, you can see that surgically we'll fix about 95% of geriatric or frailty-associated hip fractures. but really we're only chasing about 10% of those geriatric pelvic fractures. Yet, and I'll show some data on morbidity and mortality, it seems like they behave very similarly in the setting of patients who can't mobilize. And so I paint this as at least a little bit of a backdrop about where we're coming from. And part of the thing that you should be thinking about, at least I think about, is, well, why is it so different, right? If this were a distal femur or a mid-shaft femur or maybe a proximal tibia, maybe we'd be more aggressive, but for some reason with the pelvic ring, we tend to be a little bit more shy in terms of fixing them so they can mobilize and they can get out of the hospital and go home, and all the benefits that we know happen with geriatric hip fractures. I think part of this is that with geriatric hip fractures, there's been some surgical advancement, right? Cephalmedullary nails have really optimized and made geriatric hip fracture treatment relatively straightforward. Most orthopedic surgeons can do a arthroplasty, either a hemi or a total arthroplasty, cannulated screws. So the treatment options for hip fractures are probably more straightforward, for lack of a better word, than they are for pelvic ring. And I think surgeons' familiarity with that is also part of the issue. But if we were to take that same approach in terms of treating these aggressively, or at least less conservatively than we do now, could we see better patient outcomes with patients who have fragility fractures of the pelvis? When you look at yearly incidence of pelvic fractures, what's interesting is that the number of high-energy pelvic ring injuries, which is, we're calling patients under 60, is relatively flat. That's the bottom blue line. The overall incidence of pelvic fractures is increasing over time, driven predominantly, almost exclusively by patients over the age of 60. And so as you look at this data, you start to realize that this is starting to become problematic. And if you look at this curve, it actually is very eerily similar to the curve that was in place for geriatric hip fractures. The focus of our talk is going to be on fragility fractures of the pelvis. And there are about 150,000 annually in the U.S. The incidence is growing predominantly because, like everything else, aging population, living longer, more active. We know that our current strategies that we have historically used for high-energy pelvic ring injuries may not be consistent with treating geriatric pelvic rings. We know that conservative management has longer hospitalizations. There is a loss of independence, and discharge to either a skilled nursing facility or to a nursing home is actually relatively high for fragility fractures of the pelvic ring that are treated non-operatively. There's also a high rate of mortality, not dissimilar to geriatric hip fractures. When we think about a fragility fracture of the pelvis, there's sort of two different models or two different types. One is the acute fragility fracture. This is no different than the patient I presented, doing well, has a fall, now has ambulatory dysfunction, has pain, but it's from an acute episode, typically a low energy fall or a frailty style fracture. But then there's the second group that have typically insufficiency fractures of the posterior pelvic ring, usually the sacrum, also termed insufficiency fractures. They can be unilateral, but often are bilateral. Patients will often complain of low back pain. There may have been a fall or some other incident that started the domino effect of getting an insufficiency fracture. But these patients may also have an insufficiency fracture secondary to things like chemotherapy, cortisol or steroid exposure, or other disease processes that change metabolism, bony metabolism. One example would be hemodialysis, end-stage renal disease. These patients will often have changes to their pelvic ring. When we think about fragility fractures of the pelvis, we say, well, why aren't we fixing these? Why don't we just put screws in all of them or plate them or anything? And when you start to look at the data, I'll go backwards here. One is sacroplasty. Is the sacroplasty, I have colleagues at my institution who perform it. It's essentially cement into the sacrum, similar to kyphoplasty. I think it does a decent job maybe stabilizing the pelvis, but biologically, the cement may not be the best for this sort of poor quality bone. There obviously is concern about cement leakage. And then similar to maybe other cement type procedures, there can be adjacent level changes as well. And so I don't look at sacroplasty typically in my practice as a terribly biologic option, and a long-term solution. Another option going backwards on the screen is something called lumbo-pelvic fixation. This is where the spine is fixated to the posterior pelvic anatomy. You bypass the sacrum and provide sort of a infrastructure for the axial and the appendicular skeleton to be together. The problem here, probably the biggest problem, is implant irritation, and especially in an area that has minimal soft tissue coverage. It is an option, particularly for patients who have maybe an H-type or a U-type sacral fracture as a result of a fall, if they're a fragility style fracture. But it is a bigger surgery with potentially some compromise in terms of soft tissue. You could open and plate a pelvic ring that's potentially minimally displaced. There are better options for fixation of the pelvic ring that allow for bony fixation than an open plating. Obviously, the morbidity of open exposures to the pelvic ring, whether you're doing a lateral window or an anterior pelvic approach, you can imagine is not easy. And weight bearing through surface implants is not as it's not as desirable as weight bearing through an intramedullary implant like a screw. And the last option is minimally invasive screw fixation of the pelvic ring, the anterior and posterior columns. The anterior column and the posterior pelvic ring, the sacrum. You can also fix the posterior column with screws. The problem with screws is the bigger, you want a larger diameter screw to give us good stability. And with the shape of the pelvis, it's sometimes hard to get through the undulating anatomy with a straight screw. You know, imagine trying to draw a straight line through a curved tunnel. It can be really challenging unless you have the exact perfect alignment or perfect starting point to get a straight line through a curved tunnel. Similarly, if you have to get something into the intramedullary canal of a curved bone, you might have to go with a smaller diameter screw. So this can sometimes impact the stability that you're getting. Additionally, with patient anatomy, you can often have 20 to 30% of patients have a dysmorphic posterior pelvic ring, which makes placing screws somewhat challenging. So when we think about fragility fractures of the pelvis, we know that the numbers are going up. We know that the majority of patients are female. We know that this is associated with poor health. We know that this occurs mostly with low energy falls, mostly lateral compression style injuries. And we know that most of these patients, because they're frail, have other comorbidities. No one gets up in the morning and says, you know what, today I'm going to fall and break my pelvis. Let me make sure I stop at my primary care doctor and get optimized for surgery before I do that. What's the data look like, right? That's what we really care about. So what's the data look like in conservative management of fragility fractures of the pelvis? And as you can imagine, if you look through these numbers, they are what you would expect, especially if you start to think about and compare these to geriatric hips. 1 year mortality rate with non-operative treatment, 30%. Length of hospital stay, because it's hard to mobilize these patients, can be anywhere on average between 8 to 10 days up to 45 days. 30-day readmission, typically due to pain or ambulatory dysfunction, about 13%. Loss of independence living, up to 44%. Loss of independent mobility, 49%. And risk of fracture progression, particularly in those fractures that are underdiagnosed, 18%. This is why I strongly encourage, if you're listening, strongly encourage you to get a CT scan of a geriatric pelvic ring. If you see anterior ring injury, I strongly encourage a CT scan to make sure there's nothing in the back. We know that the posterior pelvic ring is really important in stability, and sometimes, although not common, you may have a patient who has an isolated anterior ring. But if there's a posterior ring injury, you do have to be thoughtful about, is this patient stable for mobilization? The front of the door is moving, but the hinges are also compromised. When you think about operative treatment, while there's not as much data on operative treatment as there is on non-operative treatment, we know that there's higher 1 year survival rates. We know that there's higher mobility, pain scores are better, and there's decreased risk of complications and death as a result of that earlier mobilization in these patients who are treated with operative management. I think you say, well, this looks great. Why aren't we fixing more of them? I think part of the issue is the lack of familiarity with operative management of pelvic rings, which is different than hip fractures. I mean, hip fractures are a essential part of our education and training for our learners and our residents. and in practice done quite commonly. You say, well, this is all great. Is there a way to classify these? Because not all pelvic rings need surgery. I completely agree with that. Not all pelvic fractures are unstable. And so Paul Romans out of Germany put together a classification system specifically focusing on fragility fractures of the pelvic ring. This is a German database study and looking at multiple patients across multiple years across the entire country. And while I'm not going to go through the details of this classification system, I think the key here is to look at the type 2 and type 3 patients. These are the ones that we consider operative. And when you look at the number of patients that fall into type 2, type 3, and type 4, it amounts to about 70 to 80% of your total patient population with pelvic ring injuries that could be considered unstable. As we key in on that data, you'll see that the mortality rate for non-operative treatment of type 2s is significantly different than the mortality rate if you operatively treat these same injuries. Similarly, with the type 3 and type 4, which you can clump together because they are unstable. The type 2s may or may not be unstable, and it's controversial, but type 3 and type 4s are unstable. The difference in mortality of operatively treated versus non-operatively treated pelvic rings in this frail patient population is clear based on this data. When you think about the pelvic ring, you think about all the osseous fixation pathways that exist, but understand that these pathways are not linear pathways, right? So these pathways exist all over the pelvic ring. The workhorse pathways are the anterior column or superior ramus, the posterior pelvic ring, the sacrum, if you will, and then the LC2 corridor or the AIIS corridor, supraacetabular screws. Those are the three workhorse pathways. And folks have looked at screw application through these pathways, and what they found is that one of the challenges, like we talked about, was putting minimally invasive implants across curved morphology. And the study out of Vancouver showed that there is room there for implants. The anatomy allows for intramedullary implants. The real issue is that the curvilinear nature of the pelvic ring makes it challenging to get the correct size implant into this curved bone. And so if you go back to the 65-year-old female, we talked about her right at the beginning, got a lot going on. We know that the anatomy is not straightforward. We know that implant selection and success historically has been limited. Our goal is immediate weight bearing, which some of the fixation strategies historically have not allowed for. We know that imaging is challenging. Intraoperative imaging can be really hard. There's a lot of bowel gas. There can be soft tissue in the way. The bone quality is such that sometimes you have trouble visualizing the sacral tunnels or the bony anatomy. And these patients are frail, so there's often multiple medical comorbidities, and a procedure that is somewhat prolonged in the operating room or has a lot of blood loss can be problematic. So when you think about her, you say, well, this doesn't look so bad. What are you talking about? Here's a lateral CT, right? So this is her sagittal CT showing a kyphotic deformity of a U-style or U-shaped sacral fracture. So it's bilateral, and bilateral sacral fractures posteriorly. She has a lot of difficulty ambulating. She's getting worse, and there's a conversation about treating this conservatively. But as you can see here, this is not a good deformity to have, and these bilateral sacral fractures can become problematic, which is why when we talk about getting the CT, the other thing I strongly encourage people to do is check the sagittal view. Because if you start to see this kyphotic deformity, that's problematic, and then you really have to make sure you do a very good neuro exam, bowel, bladder, lower extremity paresthesias. This could, as you can imagine, compromise the spinal cord at that level. So we took this patient to the operating room. In this case, you can see the blue indicates where the S1 tunnel is posteriorly. You'll see that we're able to navigate around the sacral tunnels with these curved tip wires. You can see the anterior sacrum there, so we're not violating the bone anteriorly. And placement of these large 9.5 millimeter diameter curved implants in the posterior pelvic ring, two of them to provide stability. They're safe in the sense that they're not compromising the sacral tunnels. They're safe in the sense that they're not violating the anterior aspect of the sacrum, so the L5 nerve root's intact. They're large, taking up a lot of volume, providing stability across the entire posterior pelvic ring. Imagine putting new hinges on a door that's unstable. And this is what the post-op CT looks like, showing that the implants are safe. and stabilizing that kyphotic deformity. This is her 4-week post-op note written by my PA. She's recovering at home, doing very well, walking independently, and reports improvement in pain. And I can assure you that my PA did not know that I was making this presentation, and I didn't write this note, so I was not biasing the data, if you will, if you want to call this data, but this anecdotal note, if you will. But you can see that, for her, it was different, right? She was admitted to the hospital. We had her transferred in. We fixed her, and within a couple of days, she went home on her own. This is a 70-year-old female. She has metastatic pancreatic cancer. She's on a chemotherapeutic agent and part of a clinical trial. She starts and has a history of chronic cervical spine and low back pain, and does not provide any kind of a history of trauma. She gets acute new onset, what people are calling low back pain. She's evaluated by ortho spine and referred to our ortho trauma practice. She also sees oncology as well. MRIs are obtained which show a fragility fracture of the posterior pelvic ring. It's essentially an insufficiency fracture. It's not considered pathologic. We had our oncologist weigh in. We had a radiologist weigh in, and they all felt that this was not metastatic disease progression. The left is worse than the right on the imaging, but there's no mass effect. There's no cord compromise or anything like that. And she has now transitioned from walking independently, where she's forced to use a walker to ambulate. And you might say, well, Samir, you're really aggressive. You're fixing these. And that's actually not true. We actually continued her with the walker. We told her to start vitamin D. We asked that they maybe alter her chemotherapy to an agent that may not be in a trial, so we know what she's getting or not getting, if you will. She stopped her methotrexate, and I told her to come back in 8 weeks. She comes back at 2 months, and she's more miserable than she was when I first saw her. Her pain is worse, and she has even more dependence on the walker. And really, she says to me, and I remember this because she had metastatic cancer, and her projected survivorship was not very long. I remember her saying to me, I just want to ice skate again and walk with my grandkids. And I'm thinking to myself, at 70, I don't know if I would ice skate, especially with a frail pelvis, but it just struck me that she had these very specific goals in mind. And so we said, well, we can fix you, but you can see here that she's got a dysmorphic pelvis, at least in the upper sacral segment. So this could require 2 approaches, 2 screws placed minimally invasively, one from the left, one from the right, and then a second screw at S2 to go across the posterior pelvic ring, which stabilizes insufficiency fractures. That could be done unilaterally and be a trans sacral screw. And so here you can see we're putting in the first screw. We're going to go from one side, and we're going to go all the way across. So we're going to go across that dysmorphic sacrum, where here I can't get a straight screw across in that picture on the left, in the upper sacral segment. And so I'll put in this curved implant around the S1 nerve root so I don't compromise it. It'll go across the back, and then a straight screw in S2. We did this actually as an outpatient procedure on her. She was neurologically intact. We did obtain a post-op CT while she was in PACU. She was a discharged weight-bearing tolerable walker. I gave her no physical restrictions, and I let the oncologist manage her pain medication and her VT prophylaxis given her cancer history. Post-op CT showing that the implants are safe and not compromising the tunnels. And this is her 3-week follow-up visit. Again, my PA saw her, and you can see the comment at the bottom. She was able to ambulate with walker with improved posture, and I think it's supposed to be an improvement in quality of life, not and improvement. And I remember her coming back at one of her follow-up visits saying that she was able to do what she wanted to do. She unfortunately passed several months later due to her cancer, but did it in a way that was on her terms. The last case I'll share with you is a 77-year-old female with a pathologic acetabular fracture. It's like a pelvic ring, similar concept. She is not really a candidate for a hip arthroplasty, and so that was not really an option for her. She is a physician, and she wanted to have some pain relief and be able to mobilize, recognizing that doing a hip arthroplasty on her was not ideal. We were able to place 2 screws minimally invasively through her pelvic ring, one along the anterior column of her acetabulum and one along the posterior column of her acetabulum, all done percutaneously in the supine position through 2 small incisions, minimally invasive, to be able to give her the stability in her anterior column, posterior column, acetabulum But similar to geriatric fragility fractures of the pelvic ring, these geriatric minimally displaced acetabular fractures present similar challenges. So as you think about fragility fractures of the pelvis, they are increasing in number. Early mobilization and pain control is really critical in my mind in managing these patients, not dissimilar to hip fractures. The surgical options, I think, have historically been limited for this patient population, and I think that's somewhat challenged our ability to do bullet point number 2. I think with some modern techniques and modern implants, we are able to now potentially mobilize these patients sooner and faster. Similar to geriatric hip fractures, I think having a treatment pathway for these patients is important, and I'm happy to talk about what our treatment pathway is, what our trigger is, if you will, to take these patients to the operating room. As you saw, not every patient goes to the OR right away, and we're not that aggressive or that intense about it. And ultimately, I think we need to reframe our discussion about these fragility fractures of the pelvis to the same sort of tune that we apply for geriatric hip fractures. Thank you for your time.